Hello class and welcome to another micro-learning. Today we're going to be talking about stroke. So some learning objectives: describe the risk factors for stroke, how we're going to prevent stroke. That goes back to your health promotion and primary prevention. Implement the nursing process for the acute management of stroke. Evaluate the differences on what we're going to do based on if the patient has a hemorrhagic or ischemic stroke. So what is a stroke? This is some review here. Blood is supplied by two major arteries, the internal carotid and the vertebral arteries. The brain dies quickly. You become altered in 30 seconds, and it stops within a few minutes, with death resulting in 5 if blood flow is completely cut off. Stroke can be divided into two main types, ischemic and hemorrhagic. So this would be the bleeding. This will be the clot. Ischemic stroke results from a formation of a blood clot. Thrombotic clot is if it's there and you have vessel wall injury and it's localized to there, or embolic, it came from the different area, leg, wherever it came from. TIA, or trans-ischemic attack, is a precursor for stroke. And then high-risk groups, those who smoke, those who have hypertension, diabetes, and black males especially is a high-risk group to have a stroke. So I put two pictures here. Here is the big types of stroke, hemorrhagic. You see it here. We have a rupture of a vessel. What causes that? Most common cause is going to be hypertension. And then ischemic stroke, where a patient has a clot either localized to the vessel wall or it travels up into their brain and causes an issue. So here's a little video of that type of action. So I always think it's funny when students are learning this. You think of a clot as a little tiny thing, but if you look at that video, you just saw it. All of those inflammatory markers and platelets come down, and you have this actually huge clot when they pull it out of the patient. So recognizing a stroke, fast exam is kind of like the layperson. This is really taken over. The patient may have facial droop, arm weakness, slurred speech, right, speech difficulty, and then the time that we have to call 911. We as a nurse upgrade this, and you probably have already completed this or will complete it, the NIH stroke scale of how we evaluate patients' level of stroke and what, at the current moment, what symptoms they're having of that stroke. And I always put this, I love this infographic here. If you see it, it's got time going around here. This is actually a blood pressure, but I always think of it like time, right? Time is brain. So the longer you stay or the higher your pressure, you're going to have a bad brain issue. This slide's always good, and you can pause if you want and kind of read it. I'll step out of the screen so you can read all the way through. But it's always good to know if my patient has a right or left-sided stroke, the symptoms are going to be different. And we always think of like right brain damage, left motor issue. But right brain damage, a lot of things I like to highlight is like impaired judgment, impaired time concepts, impulsive. So I always think of this when I have, me clinically, I mainly work in geriatric care. When a patient has a right side brain injury, I always think as their provider, hey, fall. They're going to get out of that bed even though you tell them not to. So that's like a big one I think of because of that impaired judgment. Versus left, they might have awareness of the deficits, they might have impaired communication, language, math issues, and then they're going to have the right-sided muscle. But these are easier to overcome than the brain issues, right? We can work with this, do assistive devices and stuff, but safety is a big concern, and when they have right-sided stroke, that always heightens my awareness of it. So what do we do for stroke? Medical management. We want to prevent it, so if we can, we'll use aspirin, Plavix. Both may be used in certain situations. If they have AFib, we want to make sure that they're on anticoagulants, and hopefully you guys can think of some of those, such as like Eliquis would be our 10A, or we have vitamin K ones like warfarin. Statin therapy, highly recommended. Even if our patient doesn't have the labs of high cholesterol, they're going to be on high-dose statin. And then for acute stroke management, we're going to follow ABCs if they need it, right? If they need their airway managed, if they have breathing issues, circulation. And then we're going to give, a lot of times, if they meet criteria, IV, TPA, or TNK TNK I put in there because a lot of hospitals are using it. I think when the newer guidelines come out for 2025 AHA, this might be part of it, but right now TPA is the big one. And then endovascular therapy if possible, where they go in and actually get that clot out. And that's for ischemic type strokes. Hemorrhagic strokes, we're going to focus on blood pressure management, making sure that we are not causing further bleeding in their brain. And we may treat it with neurosurgery or others if we have a large hematoma or bleeding in the brain. So diagnostic studies, this is where it always gets interesting. When a patient has a stroke alert, so the rescue calls it, I'm doing their radio, bringing back times. They call in the stroke alert, or you hear it overhead in the emergency department, or you're on the floor and you get one. We are always going to first do a non-contrast CT to get that initial stroke evaluation. From there, a lot of times we'll do a CT with contrast or MRI. So the big thing to know is when the patient comes in stroke alert, the first thing we want to do, CT with no contrast, and then go from there. Why, you may ask? The big reason is when we do a CT, we don't want to see the blood flow initially, so we can see if there's bleeding. If we give them a bunch of contrast, then it'll go into that area and it'll be a huge mess. So we do a CT without and then look at the blood flow. Diagnostic labs, we're going to do coag studies to see, hey, are they having this hemorrhagic stroke because they're on Eliquis? So we want to make sure that we do coagulation studies, A1C, lipids, and then evaluate their stroke risks. Cardiac eval is always going to be a part of that. The main one we're going to do is an echo, right? Transthoracic or transesophageal echo. And why we're doing that is we want to see if, number one, if they have a clot in their ventricle, or number two, if they have like, say as a child, for example, like we have a lot of young women especially that I've taken care of that have a patent foraminal and they develop a clot in their heart and they need surgery and their presentation is actually for stroke because the clot traveled to their brain. So that is why they'll always get an echo. Nursing management, safety is always a big thing, right? When you get done with school, you want to make sure you keep the patient safe. Monitor for urinary retention. This happens a lot in our post-strokes. Immobility, use VT prophylaxis. But we want to make sure if we're giving them DVT prophylaxis, right, thromboembolism, if they have a hemorrhage, I'm going to abbreviate hemorrhage, if they have a hemorrhage, then we don't want to give them initially, I'm going to put blood thinners, but you know what I mean, depending on what you work at, we don't want to get them medications that cause more bleeding. These type of patients with hemorrhagic will get SCDs, and with ischemic, they may get medications like Lovenox or heparin. Constipation is common. Make sure that we give them medications for that. If they're eating, if their GI system is working but they can't swallow anymore, we want to still use the bowel. So that could be like a PEG tube, NG tube, some type of tube to get them nutrition even if they can't swallow. And then the swallowing precaution, we're always going to keep our patient NPO until we make sure that they can swallow. And a lot of times you guys will do that as a nurse. You'll give them a glass of water to drink and then see what happens. So let's do some NCLEX questions here. So a client with a recent history of TIA, high risk for stroke, TIA, is prescribed low-dose aspirin daily. Which of the following statements made by the patient indicates the teaching about this medication has been unsuccessful or the need for further teaching? So we're going to try to find the wrong answer when it comes to aspirin. I will call my doctor immediately if I experience dark stools. Sounds good. I will take my aspirin with my statin medication. Those can be taken together. That's testing if you know that. If I experience stomach upset, I will take an antacid with the aspirin. I should use the enteric-coated aspirin to reduce stomach upset. That sounds good. Why is C a wrong option? Hopefully you're thinking at home you cannot take antacids with pretty much any medication. So if they have stomach upset, they'll want to take this at least 2 hours before or after medication. So we don't want to mix the antacids. The healthcare provider is assessing a client in the emergency department who has been found to have a hemorrhagic stroke. So this is the brain and they're bleeding. Let's put the red on there. They're bleeding all in the brain, right? Which of the following is a priority assessment? And I put this question at the end because I wanted to highlight it at the end. All these things I had taught you except one. So we learned that we want to do a 12 lead, right? We want to check their heart. I said echo, those type of things we want to do. We want to do a swallow eval because we want to make sure they can swallow. We want to do a lipid panel to see where their cholesterol is. But priority for this patient is we want to check their pupils. And this is something I wanted to highlight, that the pupils are a significant issue in patients that are bleeding in the brain. Pupillary response will dictate a lot of the care, right? They might have a blown pupil, they might have a non-reactive, but that is a priority assessment with a patient that's bleeding in their brain. Oh, we got one more. A client arrives to the emergency department via EMS as a stroke alert. Slurred speech, left-sided facial droop, left arm weakness. So we are thinking right-sided stroke. Which of the following actions by the nurse is a initial priority? Okay. Perform a comprehensive stroke assessment, including the NIH stroke scale. Prepare the transfer of a patient for a CT scan of the head. Transfer the patient to the neurocritical care. Establish IV access to administer thrombolytics. Consult speech therapy for evaluation. All of those are good, plausible things that we're going to do. Initial priority. What is our initial priority? What is the first thing? If we go back, let's go back to it. What is the first thing I said that we need? Initial priority. CT scan, right? So as we go over here, we want to prepare and transfer the patient for that CT scan, right? We'll do an NIH later. We might put them in critical care. We may give them TPA. We may need speech. But our initial priority for this patient is to do a CT scan. So some key takeaways. Ischemic, remember that is a clot. Hemorrhagic is bleeding, and TIA is a precursor that could include both, mainly ischemic strokes. Timely action matters. We need to get them into CT scan, and we need to do rapid treatment, whether it be TPA or taking the clot out directly. Prevention is so important. We want to make sure we lower their cholesterol, getting their blood pressure in control, healthy diet, good exercise. Holistic nursing care, taking care of the patient, making sure they're not falling, checking their bladder for, see if their bladder has tons of urine that they need a Foley catheter place. And then interdisciplinary approach is very important. We're going to collaborate with a lot of people on stroke care, whether it be PTs, speech, the docs, the providers, the NPs. So a good interdisciplinary approach is how we're going to take care of these patients best. Hey, thank you guys for joining me so much today on a micro learning on stroke.